Full presentation. Our next speaker is Dr. Kumar Doctor, and he'll be talking on the long and the short eyes.
Morning to you all. I'd like to thank Dr. Arup and Nazneen for this opportunity given to me. I'm going to talk on optimizing IL power calculation in long and short eyes. I have a little video. I would like to thank Dr. Shivani, who is my associate, to have helped me compile this presentation. I'm just going to give two examples and then show a little video. So this was a patient with 55-year-old post-myopic LASIK, had nuclear sclerosis and planned a multifocal IOL. So do I do multifocal IOLs for post? They are very demanding, and I do them, yes, there is no doubt about it. So here I'm showing the new readings from the Anteron. It's an optical biometer made by Heidelberg. I was very impressed, and I ultimately decided to go ahead with this technology. How does it help me? So this is the actual length measurement that you have a 24.29, ACD of 2.63. It also gives you lens thickness, which is an essential part for expected lens position. Keratometry and white to white diameter. So we go ahead and do this. Now, according to the Barrett True K, we got a 22 as a minus 4.27. According to the calculations on the Anterion, of course, we got the same reading. So you saw that 22 is 0.16 and 22.5 is 0.18. So these were the two readings that I got. Now I also got IOL master reading done. So when they are post-refractive cases, I prefer that I do an IOL master. I compared it with the Anterion to conclude what's happening. I also did the ACRS calculation. So the ACRS calculation on IOL master was 22. ACRS calculation using Anterion readings was also 22. So I went ahead and stuck to the Anterion reading because that's what I have. And my patient went ahead with a successful trifocal Synergy IOL with a 22 diopter, and the post-op was 6.6 part with an N6. The autoref showed that. All of you know that autoref is not very accurate as far as multifocal IOLs are concerned. As far as a short eye is concerned, a hyperopic patient with a very, very shallow anterior chamber, and the patient wanted a multifocal IOL. So you can see the short, small anterior chamber, a peripheral iridectomy, which is caught on the anterior segment OCT from the Anterion. Here, the axial length is 21.30. The ACD is 1.92. The lens thickness is normal, as you can see, 4.37. Keratometry and a white to white, which is small, which is 11.5. So went ahead here in this case, again I did a Hill RBF. So at our center, we use the Barrett, the Hill RBF, sometimes the SRKT, depending on the actual length. So we do 3 formula calculations for each eye. And here you can see that the Hill RBF said to use a 31.5 on the Anterion. With the Barrett, I got the measurement of 31 as 0.03 and 31.5 as minus 0.35. So this is what I got on the Anterion. I'm just showing a little bit of the surgery here. Very, very shallow anterior chamber. I had performed a Z8 femto, made the incisions with the laser itself, picked up the rexis, went ahead and did phacoemulsification. Now, very surprisingly here in this case, I found that in spite of clearing a 4.37 lens, I did not find so much space as far as the IOL was concerned. And here I'll show that I'm doing bimanual IA. After a femto, the bimanual IA is almost a little different than the normal IA where we get. So here I'm implanting a 30.5 diopter IOL. You can see that 30 with multifocal IOL. So going ahead and placing the IOL in the bag. Once this goes in, just make sure that it's placed horizontally. We got Virion technology, so we are aligning the toricity of the lens, which is at 6 diopters, then removing the viscoelastic from the front and back. So here, a very, very shallow anterior chamber, you have very, very little space of 1.92. So a Technis multifocal, a 31.5 with an add of 3.25, and we got excellent results. So this was a short eye, very small anterior chamber, but we got very good results. Now, one case I'll show you, some of you may have never seen this. Small eyes can be classified according to anterior chamber depth and axial length. This video will demonstrate the challenges found in 2 cases, extremely short axial length and a small ACD. No, you can keep it on, but can you reduce the volume? Keep it on.
Profession with high hyperopia was referred for refractive correction. On examination, her best corrected visual acuity was 20 by 40 part in both eyes with a correction of plus 12 diopters. On slit lamp examination, she had a normal sized cornea in a very shallow anterior chamber, and gonioscopy showed occludable angles with a normal IOP. She underwent a prophylactic YAG-PI in both eyes. Her dilated fundus examination revealed heaped up optic nerve head and retinal vessel tortuosity with an attached retina in both eyes. OCT macula was normal in both eyes. A detailed imaging was performed on tomography, optical biometry, and a corneal wavefront and an ocular wavefront analysis was done. What the test revealed was indeed unique and surprising. Her white-to-white diameter was 10.7, her ACP of 2.68, and her lens thickness of 4.27 in both eyes. Her axial length in OD was 14.85 and OS 14.89. Her average keratometry in both eyes was 56, a very steep cornea. Iron power calculation by different formula varied from 49 diopters to 65 diopters. These scans showed a thick chorioscleral complex, 2.06 mm in the right eye and 2.23 mm in the left eye. On conclusion, it was an extremely short eye, a very steep cornea, a very shallow anterior chamber, and a normal lens thickness, almost 1/4 of the whole eye. A thick chorioscleral complex, so a non-ophthalmic eye, or shall I say, a thick ophthalmic eye. Set the wheels rolling, made many calls, wrote emails, asked, discussed, thought, and reviewed literature. The patient was planned for clear lens extraction. Decided to go ahead with a customized hydrophilic foldable IOL of 65 diopters to be injected through a small incision of 3.4 millimeters. The challenges faced is IOL power calculation, manufacturing a customized high diopter power IOL, and injecting the same safely through a small incision. Well aware of the various complications known in non-ophthalmic eyes, adequate precautions were taken before, during, and after surgery. Patient taken up for femto, plexus, and a 4-quadrant division of lens performed. A 0.75 millimeter sideport incision made and a gentle release of the aqueous, replaced by an OVD. Using a microrhexis forceps, the CCC was grasped out. Bimanual IA used for aspirating the lens material. Globe not allowed to collapse because of the use of the OVD. Main incision of 3.4 millimeter made. 65 diopter, highest ever IOL manufactured, was loaded, placed in the cartridge, and then injected. Loaded the hydrophilic IOL. Significant amount of pressure needed to push the 1.9 millimeter thick IOL through a 3.4 millimeter cartridge. Precaution taken to not let the globe collapse. IOL placed in the bag and the trailing haptic dialed into the bag. Suture placed, bimanual IA done for OVD removal. Air placed. Post-operatively, overwhelmed to see the first day post-operative visual acuity of 20 by 60 and a refractive error of -1.5 spherical with a -1.75 cylinder at 20.
So this was a non-ophthalmic eye, and Hoffer-Q is the formula that works the best in my experience with such extreme cases. We had one more case, but because of paucity of time, I won't show that. But in long and short eyes, optical biometry is, I think, an essential tool besides immersion. So I know that, as rightly mentioned by Arup, that according to me, contact biometry should be banned. And it's not very expensive to shift from contact to immersion. I agree that optical biometers are expensive, but it's a wise investment because your accuracy will give you results, which will give you a return of money, etc., etc., etc. So this this was 3 examples. Thank you very much, Arup.
The well documented cases and the videos. Our next speaker is Dr. Meena Chakrabarti. Ma'am will be talking on posterior segment pathologies and vitrectomized eyes.
So Kumar, your cases were very well demonstrated. So what I just wanted to convey is, we have sorted out the problems with high myopia, with the optical biometry and the advanced formulas. That is actually no longer so difficult for us. But the problem with the short axial length still exists, the getting which formula to use. Hoffer Q, worked well for you, but I would suggest that if we use multiple formulas and then see the amount of agreement between the formulas, and then take a call and tell the patient that we may require a secondary intervention. What do you say, Ramesh?
Totally feel the same that these short eyes are a big problem. There's a 2022 review comparing the various formulas. We show that if you use Barrett and if you use DGS formula, these tend to give you the best results. So the Pearl DGS is a new formula which has come. It is made by Getaniel and group.
Yeah.
So we can expect to see some kind of a clarity in the next 2 years or so.
Okay.
Only thing was that in the Barrett, it didn't accept a 57K. It said beyond normal limits,
Right.
it wouldn't accept.
Right.
So I got stuck at that level. I have no experience with the other formula you mentioned.
Right.
So as you saw in this case, I have done all the calculations, including, and I got a range from 49 to 65. So there is no agreement amongst all this. But luckily I went with instinct and
Yeah.
talked to a lot of people and they said, in short eyes, Hopper works the best.
Yeah. Use the phone because we are recording all the sessions, all the speakers. Yeah. Can you repeat?
So
Yeah.
I got, because of the 57K, many IOL calculators did not accept a 57K entry only to do the calculation. So that is where I was getting stumped, and I couldn't go to the next level only because they say beyond normal limits and it stops there. That was the problem I faced.
Dr. Kumar, your patient is doing extremely well. So Hoffer-Q has worked for you.
So retrospectively, it was a good conclusion.
Yeah.
But I feel the future generation of doctors will be tending to use Kane and Evo formula. They'll be using the current generation formulas.
I mean, if you speak to the established gurus in IL power calculations, they say Hoffer Q belongs to an older generation, and as Ramesh rightly mentioned, that Kane formula, Evo formula, maybe are the formulas look forward to.